بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good afternoon, everyone. I'm so delighted to be here this afternoon. Although this is a virtual meeting for me, I wish I was able to make it to Egypt, a place that I really admire and love. I have many friends in Egypt and many Egyptian friends here in Saudi Arabia. So we are definitely one country, and it was really unfortunate that I could not make it this time, but hopefully, inshallah, next year. I would like to thank Dr. Professor Rada and her team and the organizing committee for inviting me to be part of this conference. The subject that I'm going to talk about today is medullary thyroid cancer, with special emphasis on molecular genetics and their implications on the management. My name is Alzahrani. I'm a consultant endocrinologist at King Faisal Specialist Hospital and Research Center in Riyadh, and a professor of medicine at Faisal University in Riyadh. I have nothing to disclose, and the agenda of this 20 minutes has to be focused. So we are going to have a brief introduction. Then we'll talk about when and how to use RET testing in medullary thyroid cancer. We'll talk about the principles and approach to the management of localized medullary thyroid cancer. And then we'll talk about the management of metastatic disease. So, as you all know, medullary thyroid cancer is not that common. It's much less common than the differentiated thyroid cancer, but it is a very special type of cancer with its own course, characteristics, management, and outcome. And again, overall, around 5% of thyroid cancer are medullary type. But again, within the medullary type, we have several subtypes. The most common is the sporadic medullary thyroid cancer, which basically means a patient who has no family history comes with thyroid mass or thyroid nodule, and it turns out to be medullary thyroid cancer, no family history, and if you happen to test him for genetics for RET mutation, it will be negative. And this is the bulk of patients. Around 80% of patients will be sporadic medullary thyroid cancer. Then we have the familial type. 20 to 25% of patients have familial types, and it comes in different formats. It comes as familial medullary thyroid cancer isolated. In other words, there's no other features of the MEN2A or 2B. The patient just comes with medullary thyroid cancer, and he or she has family history, or RET oncogene is positive. But it also comes as a part of MEN2A, which includes also leukocytoma and primary hyperparathyroidism, and sometimes additional features. And it comes also as part of MEN2B, which is fortunately rare because this is the worst type of medullary thyroid cancer. And in MEN2B, we have medullary thyroid cancer, leukocytoma, ganglioneuromas, and melphagoid habitus. Now, the whole genetics has been based on this gene called RET oncogene, which is a gene that is located on chromosome 10. And as you can see, this gene encodes for a large protein that you'll see on the next slide. So this is the protein. This protein actually is a transmembrane protein and with large extracellular domain and large intracellular domain. And this is a tyrosine kinase receptor. So it's basically one of the members of the superfamily of tyrosine kinases. Mutations in this genes at different domains and different parts are associated with medullary thyroid cancer, either as isolated familial medullary thyroid cancer or as part of MEN2A or part of MEN2B. And you can see the location of those mutations in a very specific location. For example, MEN2B essentially is caused by this mutation called 918, located on exon 16 of the RET oncogene. And 634, for example, is very characteristic of MEN2A or familial medullary thyroid cancer, and it is in the extracellular domain. Now, the reason I'm mentioning this because there's a strong genotype-phenotype correlation. So certain mutations are associated with strong or with very aggressive disease, and therefore should be managed differently. And we'll see this in the management. So how to interpret RET oncogene testing when you do it for an individual with MAN2 or with medullary thyroid cancer? The beauty of this testing is that if you have a negative test, essentially you have no predisposition to medullary thyroid cancer, familial medullary thyroid cancer, or MAN2A or 2B, and your risk is similar to the rest of the population. So you can forget about it, especially if the patient is a member of family with familial medullary thyroid cancer or MAN2A or B, and his test turns out to be negative. He can be reassured that he has no increased risk. His risk is similar to the rest of the population. By contrast, if the RET oncogene positive testing turns out to be there or turns out to be positive, then this patient has, or this subject or person has a high likelihood of medullary thyroid cancer in the future with almost 95 to 100% likelihood. And therefore, we come to the discussion of prophylactic thyroidectomy, removing the thyroid gland before the patient develops medullary thyroid cancer. So this is the very good thing about genetic testing in medullary thyroid cancer. This is from the American Thyroid Association guidelines, what to do when you have positive RET mutation. So if you have a child and he has RET mutation positive, the next question is, what is this mutation? This mutation is the very highly virulent or aggressive mutation 918. This is considered to be the highest risk. Those patients almost certainly will develop very aggressive medullary thyroid cancer, and prophylactic thyroidectomy needs to be done as soon as possible, certainly in the first year of life, because of reports of patients developing medullary thyroid cancer in the first year of life. If the patient has 634, which is the second most aggressive mutation, it is labeled by American Thyroid Association to be a high risk. Then again, this patient is at a very high risk of developing medullary thyroid cancer, and the indication to remove or to do prophylactic thyroidectomy is before 5 years of age. All other mutations are classified as moderate risk. You can see there is no low risk. They are moderate risk. And in this situation, you don't have to rush and do prophylactic thyroidectomy, but you need to follow those patients with annual calcitonin. And when the calcitonin starts to rise, you send those patients for thyroidectomy. But I think this is very nice, very straightforward recommendation from the American Thyroid Association guidelines. So that's for the prophylactic thyroidectomy and the genetic testing and what to do with it. What about if a patient already comes to you with a thyroid nodule and the FNA is showing that this is medullary thyroid cancer? How to approach this patient? This algorithm is also very useful and very nice, and although it looks complicated, but we'll walk through it and it's easy. So when you have a patient with thyroid nodule, FNA diagnosed medullary thyroid cancer, the essential investigation initially is to do ultrasound of the neck and measure serum calcitonin and CEA and do DNA analysis for RET mutation. Based on this, you can plan the next step of management. So if RET mutation is negative, this is not a familial disease. We don't have to worry about hyperparathyroidism or fucocytoma. We have to focus only on medullary thyroid cancer, which is sporadic in this case, and we will see what to do next. If, on the other hand, RET is positive, this is a familial type of disease, and we have to make sure that the patient does not have primary hyperparathyroidism or fucocytoma before proceeding. If they don't, the management again is similar at the stage 2 RET negative disease. On the other hand, if they have primary hyperparathyroidism or fucocytoma, we need to deal with it either with, at the same time, with medullary thyroid cancer or even before dealing with medullary thyroid cancer in the case of pheochromocytoma. So if the patient is RET negative or has no evidence of pheochromocytoma or hyperparathyroidism but is RET positive, the next thing to look at is calcitonin. If the calcitonin is less than 500, it is very unlikely that this patient has distant metastasis. And in this case, we can proceed with total thyroidectomy with or without cervical lymph node dissection, and that would depend on the ultrasound findings. So if the patient has lymph nodes, we would have to do cervical lymph node dissection. If there's no lymph nodes, everything looks okay, then the patient may have total thyroidectomy. And then if there is residual after the surgery, you may consider extended beam radiotherapy or other types of local therapy. If calcitonin is more than 500, there is a very high chance that the patient has distant metastasis. And this takes us to the next slide, where before proceeding with thyroidectomy, you need to do CT scan of the chest, CT scan or MRI of the abdomen. You may even consider doing bone scan or PET scan to make sure that the patient does not have distant metastasis. If there is no distant metastasis, M0, you proceed with total thyroidectomy with or without cervical lymph node dissection. On the other hand, if there is metastasis, M1, still you need to do total thyroidectomy and deal with the distant metastasis. You treat regional disease, and then if there is distant metastasis, you can treat this with either clinical observation, if it is not progressive, and if it is progressive, you can consider either a clinical trial if you have one, or proceed with systemic therapy with TKI that we will talk about in a minute. So I think that these two slides basically summarize how to approach a patient with medullary thyroid cancer, the emphasis on the ultrasound of the neck to delineate the disease, measurement of calcitonin to predict distant metastasis, and doing RET-mutation to make sure that the disease is not familial and we are not missing also hyperparathyroidism or pheochromocytoma. But what about if the patient has already metastatic medullary thyroid cancer? How to deal with metastatic medullary thyroid cancer? Well, few facts about distant metastasis. Unfortunately, medullary thyroid cancer frequently present with metastasis. So 10% of patients have detectable distant metastasis at the time of diagnosis. And during the next 10 years of follow-up, many of them will develop the distant metastasis up to 50% of patients, especially if after surgery they continue to have detectable calcitonin. Distant metastasis can be associated with diarrhea, flushing, and they are frequently in many sites. Lungs, liver, skeleton, and sometimes brain are the usual places for distant metastasis, and it's usually multiple. Now, one of the most important predictive factors for survival and for prognosis is actually what is called calcitonin doubling time. So if you are following a patient over a few years and you find that his calcitonin doubling time is more than 2 years, in other words, if it takes more than 2 years for calcitonin to double in its level, then those patients do very well. The tumor is not very aggressive, it's not proliferating very rapidly, and the 5 and 10 year survival is around 100%. If it is less than 6 months, this is a bad sign, and the 5 year survival is only around 23%, the 10 year survival is only 15%. In between, as you can see on the slide, it is not bad, but still not as good as more than 2 years. So between 6 months and 2 years, 94% at 5 years, and 64% at 10 years. If the disease is not progressive, we can use local therapies, and we don't have to rush and give patient tyrosine kinase inhibitors. Local therapy may delay the need for systemic therapy, and there are many things that we can use to treat those patients with local therapy, including another surgery, external beam radiotherapy, radiofrequency, cryotherapy, cement injection, and tumor embolization. So this is used for a disease that is metastatic. You cannot get rid of it, but it is stable. On the other hand, if the disease is progressive, the only thing in our hand is actually using kinase inhibitors. And this slide is just showing you some of the available kinase inhibitors. For medullary thyroid cancer, Prasetinib and Carcinoma are the two FDA-approved drugs for medullary thyroid cancer, and there are two new ones that we will talk about in a minute. The other tyrosine kinase inhibitors are used for other types of cancer. For example, Lymphatinib and Sorafenib are used for differentiated thyroid cancer that is metastatic and radioactive iodine refractory. Let's talk about those two drugs that are FDA approved. So Prasetinib works on basically the cells by inhibiting RET oncogene, epidermal growth factor receptor inhibition, TGFR receptor inhibition, and they basically calm down or decrease the activity of these two signaling pathways, the MAP kinase and the PI3K-mTOR pathway. So this was tested. The Prasetinib was the first drug to be approved for medullary thyroid cancer. It was tested in this trial called Zeta trial, and you can see this is randomized phase 3 trial, 2-to-1 randomization, placebo versus Prasetinib, 300 milligram daily, and patients were followed up. And the summary of this, you can see it on this Kaplan-Meier analysis. Patients who received Prasetinib did much better in terms of progression-free survival compared to patients who received placebo. And you can see the statistics here, very significant reduction in the hazard ratio of progression-free survival, with median progression-free survival in Prasetinib group of 31 months compared to only 19 months in the placebo. The second drug is Cabozantinib, and again, you can see on this cartoon where it works. It inhibits RET, c-MET, EGFR, and this was tested in another trial called the EXAM trial, and this is again the Kaplan-Meier analysis of this. You can see patients who received Cabozantinib did much better than the placebo, with progression-free survival of 11 months versus only 4 months for placebo. And again, this is approved for use in progressive metastatic medullary thyroid cancer. Two new drugs were approved last year. They used to be referred to as LUXOR 292 and Blue 667. Today, we know that this is Silvercatinib, this is Prasetinib. As you can see, they have very high activity against RET. The beautiful thing about those drugs, they are more specific. They inhibit RET, and therefore they are associated with much less side effects than Prasetinib and Cabozantinib. This is a New England Journal of Medicine article that was published last year or the year before, and based on which Silvercatinib, one of those, the LUXOR 292, was approved for medullary thyroid cancer and actually for any RET gene altered cancer, not only for thyroid, but also for lung and for differentiated thyroid cancer and medullary thyroid cancer, as long as they have RET oncogene alteration. I just should mention that in medullary thyroid cancer, the RET alteration is point mutation, as you can see here, while in lung cancer and differentiated thyroid cancer, it is RET fusion, which means basically part of the RET is fused with another gene, and they cause what is called RET fusion. Like, for example, RET-BTC1, RET-BTC3. This is the waterfall plot of the effect of Silvercatinib in patients with medullary thyroid cancer. You can see the overall response was 69 for patients who were previously treated with Prasetinib and Cabozantinib, not treated, sorry, or previously treated. And then it was even better, 73% for patients who did not receive medication before. Overall response was 73%, and progression-free survival at 1 year was 92%. 92% did not progress. And this is the data on the differentiated thyroid cancer, small group, but again, the response is impressive. This is where Silvercatinib works. It inhibits RET oncogene, or RET-BTC or RET fusion proteins. The other drug is called Blue 667 or Prasetinib. It works on the same principle. It has almost similar effect. You can see the waterfall plot here, 60% overall response rate in patients who were treated previously with cabozantinib or tindatinib, and 74% overall response rate in patients who were treatment naive. And you can see the effect on differentiated thyroid cancer. The side effects of those drugs is really good. The profile is good. Most patients get only grade 1 or grade 2. Very rare to have grade 3 and grade 4. I have a number of patients on those drugs, and it's impressive that the side effect profile is very, very mild and excellent. This is the same thing for Blue 667. Again, you can see grade 3 is very rare, and grade 4 is almost not there. Most side effects are grade 1. Only 2 patients discontinue the drug for side effects. So to conclude, medullary thyroid cancer is rare, but it carries worse prognosis than differentiated thyroid cancer. The key prognostic factor is really early diagnosis. If you want to cure or control medullary thyroid cancer, you should strive to diagnose it as early as possible and treat it as early as possible. The treatment is surgery and complete surgery. However, of course, when there's metastasis, we have to resort for drugs. RET testing in familial medullary thyroid cancer and MAM2 gives an excellent opportunity for prophylactic thyroidectomy or cure. Metastatic disease is common at diagnosis or later during the follow-up, and the management of metastasis depends on their course. If they are stable, we can observe them and use local measures. If they are progressive, we can proceed with multi-kinase inhibitors, tindatinib, cabozantinib, or the new ones, sempercatinib and prasetinib. The new still in trial, they are no more in trial actually. They are now approved by FDA, the sempercatinib, prasetinib. They are very specific RET inhibitors, and they actually have revolutionized the treatment of medullary thyroid cancer that is metastatic and progressive. And with that, I will stop here. Thank you very much for your attention. And again, thank you for the opportunity to talk to you.